Welcome, everyone. It is my immense pleasure to welcome Dr. Lauren Rodriguez to speak to us today. I've known Lauren, luckily, for 5 years now. She's been a really phenomenal colleague and friend. We were lucky enough to do a DBT group together at the height of the pandemic, and she was a godsend
My
intern to
very first year.
help us out and have some fun together. But I wanted Lauren to come speak to us as part of this seminar series because she has a wealth of experience in complex comorbidities, and she's done a lot of work with PTSD and substance use. And I think will be a nice change of pace from the hardcore chemistry and genetics we've heard. And I know she'll be happy to take any questions. So I will give her the floor and I will move the camera so you can see the folks in the room.
Great. Hi, everybody. Good afternoon. Thank you for so much for having me today. So what I did was I kind of prepared some information just around, like Dr. Hartwell said, the co-occurrence of PTSD and substance use. So I'll kind of go through that. But please feel free at any point to interrupt me with questions or, comments as they come up. Don't feel like you have to wait to any particular point. All right, great. Let's get started. All right, wonderful. So what I wanted to do was change the slide. There we go. What I wanted to do to start off was just to tell you a little bit about me. So I graduated with my doctorate in clinical psychology from the University at Buffalo, and then came to Philadelphia where I did my clinical internship at the Philadelphia VA. And then I've just kind of stayed there. So I did my postdoc there through the Philadelphia MyRec, and then just within the last year, recently transitioned to a licensed staff psychologist, where I now do a combination of research and clinical work in the behavioral health department that focuses on PTSD and substance use. And recently, I've kind of been expanding into some specialty areas that focus a little bit more on veteran women's health, particularly around complex trauma like military sexual trauma or intimate partner violence. And then within my research, I've been really trying to expand into more of a community engagement approach, which really is not just about doing the research, but really about involving the populations who the research is focused on, so that their voices are reflected in every phase of the research that happens. So I'll talk a little bit about what that's looked like so far today. Just to start off a little bit, just because I wasn't quite sure how familiar folks were with the co-occurrence of PTSD and substance use, wanted to just kind of give a couple of like big facts about it. Is one that it's a really, really common comorbidity that we see. So in the general population, somewhere between like 10 and 61%, right, of people will have this co-occurrence. So depending on what subpopulations you're talking about, it's definitely more prevalent. And veteran populations is one of those populations. So they are much more likely to see this co-occurrence. Part of that is, again, given their military experience, where they're more susceptible to experiencing traumas, and then also at higher risk for substance use as well. So in our clinics at the Philadelphia VA, we see about 33%, or about 1/3 of veterans in our PTSD clinic also meet for a substance use disorder. And in the addiction recovery unit, our substance outpatient clinic, we actually see much higher rates. So about 75% of people presenting for a substance use disorder are also experiencing trauma symptoms or PTSD. And what's really important to know is that these symptoms are bidirectional. They definitely influence each other. As someone is experiencing PTSD, it definitely exacerbates their substance use. So they're using more heavily, more frequently, and getting more intoxicated with the substances that they're using. And that in turn is actually then further exacerbating their PTSD symptoms. So they're experiencing more intrusive symptoms, more avoidance, more hyperarousal, more difficulty with sleep, things like that. So as you can imagine, when you have this co-occurrence, it's much more impairing than having either disorder by itself. So a lot of the types of impairment that we see are really broad, and that can include difficulty sustaining or getting employment, difficulty socially in terms of interacting with friends or family, or even just with the general public, difficulty in terms of more complex mental health presentations, like higher rates of suicidality or suicide risk, things like that. And even more complicated is on top of that, having this co-occurrence makes both PTSD and substance use more difficult to treat. And one is because, like we were talking about with that bidirectionality, that they're influencing one another. And two is that because of some of the complexity in terms of the impairment and that we're seeing from the symptoms, a lot of folks with this co-occurrence tend to drop out of treatment at a much higher rate than if they are just presenting for treatment for one disorder or the other. So as you can see, this is something that's not only really prevalent, but really problematic and complicated when we're trying to treat it. So what I wanted to do today was to talk a little bit about some of my research and how it informs some of the treatments that we do at the Philadelphia VA by talking a little bit about the mechanisms of this co-occurrence. And in particular, like we said, right, why these two disorders co-occur so often and how they influence each other. So a lot of my work tends to focus on the mechanism of negative affect. So kind of looking at this model here, like we were saying, these two conditions are very related. So a lot of the time, someone with PTSD will be experiencing symptoms related to distress from their trauma, which elicits a lot of negative affect, right? Negative emotions, negative experiences. And that in turn, right, is often driving their substance use. So substance use is a way to cope with those symptoms. It's a way to escape them, kind of to numb them for a period of time. And so over time, right, we kind of see this cycle, this pattern that happens where, on the one hand, the person is experiencing this negativity related to their PTSD, and then their substance use is getting reinforced because of the negative reinforcement principles at play, where it's taking away some of that distress for a temporary period of time. But like we said, right, it's only temporary. And so in turn, those PTSD symptoms kind of flare up even more, fuels more negative affect, fuels more substance use. So we kind of get caught in this vicious cycle that tends to happen. Like we mentioned, right, substance use is effective in those short-term moments, but in the long term, it's really exacerbating the whole problem for folks. So a lot of what my research does is focus on these moments where people are making decisions about drinking. So rather than looking at studies that look at a larger time scale, right, over months or years in terms of how PTSD and substance use relate to each other, a lot of my research kind of looks at these more micro level moments of, in these minutes or hours of, somebody experiencing this distress, what is increasing their risk for substance use. And one of the processes that I look at in a lot of my research is something that we call emotional responding. So you can think of an emotional response kind of like a wave, right? Where a lot of the time somebody's going to have something happen, right? Some kind of a stimulus or trigger that's going to elicit a negative response. And they're going to have their distress kind of go up, peak at some point, right? And then eventually come back down to their kind of usual levels. So a lot of the times what I look at in my research are kind of these two components of emotional responses. And so one is, like we mentioned, that affective intensity, that peak or maximum level of how bad they're feeling. And then that affective recovery of how long does it take them to go back from being so distressed back down to normal again. And one of the things that we found in some of the research is that when folks experience these two components, that it actually has impacts on what their substance use looks like. So what we did in one of the studies, it was a laboratory-based experiment where we were looking at kind of these relationships between emotional responding and craving for use, right? How much somebody wanted to drink alcohol in the moment. So what we did was we had folks come into our lab and we had them rate a couple things. So they first rated their baseline craving. How much do you want to drink right now? And then they rated their current emotion, right? How are you feeling right now in terms of how negative and how emotionally intense do you feel? Then what we did was we actually had folks listen to a personalized trauma cue. So they had conducted this trauma interview with some of our research staff, where they talked about their worst traumatic experience that had happened to them. And through that interview, we created an audio recording that was kind of a summary, right, of that experience that the person could listen to in real time. So they were listening to an account of the traumatic experience that was serving as kind of an activating cue for them. And then immediately after they heard the cue, we had them rate their craving and affect again. And what we found was that for individuals with PTSD, that greater affective intensity, right? So those who got more distressed in response to that trauma cue was associated with greater craving for alcohol in those moments. And this was above and beyond just how negative people felt generally. So this didn't necessarily have to do with I'm a person who just is kind of more, I experience more negative emotion, but it was something about, right, in that moment when I'm triggered by this experience and that negative emotion comes up, it actually triggers this response of increased craving and increased desire to drink. And what we did was we actually replicated those results in a separate study with a community sample. And we found the exact same thing using an independent paradigm. So rather than have folks come into the lab, we actually had them, this was during COVID, so it wasn't a time where we could bring people into the lab, but we had them, instead of going through that trauma interview, we actually had people write about their trauma. So on an online survey, we had people, write about what their worst traumatic experience was. And so we instructed them to say, kind of write in the present tense, include as many details about what happened and what you were experiencing. They did that for about 20 minutes. And we found that exercise, even though they weren't listening to a cue, they weren't talking to a person, just the exercise of writing about it elicited a sufficient trauma cue response. And we were able to see the exact same thing, that for people with PTSD symptoms, those that had this greater affective intensity showed the stronger craving for alcohol in those moments, above and beyond what their general negative affectivity was like. So what we wanted to do is we wanted to expand this a little bit further, right? And we wanted to look at not just kind of a single cue, but we wanted to look at patterns of emotional responding as well. So we actually used a similar paradigm to the first laboratory study that we did. And what we did was, instead of looking at just a single trauma cue, we actually had a repeated exposure to the cue. So we could look at patterns of responding. So what we did was we did the exact same thing. We had them rate their baseline levels of affect and craving. We had them listen to the trauma cue and then rate their post cue levels of affect and craving. And we did that 3 times. So it was kind of this, phased approach that happened. And then we had a final rating of, at the end of the program, what are your affect and craving. And what we found was that, again, across these different responses, is that people actually have different patterns of responding. So on average, right, there are some people who are kind of just lower responders. So this emotional valence, the top of the graph is more neutral or positive. And then the bottom, the lower scores, mean that they felt more negative after the trauma cue. So we have some people who just really aren't affected by the cues at all, right? It's not something that affects them. We have some people who are kind of moderately affected, and then we have some people who are more significantly affected, right? They experience more negative emotion. But what was really interesting about looking at these patterns was that not only do we see that this pattern of intensity, right, how negative they feel is significant, but we can also see that there are differences in how quickly people return to their baseline levels after they've been exposed to a trauma cue. And what we found was actually that both of these things is significant for understanding what their craving response looked like. So for people who had that higher intensity, right, they felt more negative, they had higher craving. And also for people who stayed more negative, even after they weren't experiencing the cue anymore, those people also had higher craving. But for people who started to recover more quickly, they seemed to have a little bit more of a buffer. So it was a little bit more protected from that, where their craving response wasn't as intense. So we kind of took this to mean, right, that there really are important differences in how someone's responding to reminders of their trauma that really make a difference in understanding what their risk for substance use looks like.
I have a question
Yeah,
about
please
that
do.
slide.
Yeah, let me go back.
What do you, or do you make much of the baseline differences, and especially with the resilient responders having seems to be a higher baseline, and so maybe that contributed to their recovery and post-experiment?
Definitely. Yeah. So what we did in our analyses was we controlled for baseline. So in our regression models that we ran, everybody, we looked at their post-cue controlling for their baseline levels. So that way, like we said, if because there were differences,
Right.
in terms of where they started, that it's looking at kind of that difference and change rather than just the overall effect itself. But that is a great point, right? That if they're starting off at a higher point, they've got a little bit more to come back up to.
Right. Yeah, yeah, and yeah, that makes sense that you controlled for those changes, and also yeah, maybe they have a different having a different baseline is part of the reason why they are resilient, I guess. Does that make sense?
I think so, right? So you're kind of saying like that they're, like you said, they're people who kind of start off already in more of a more positive state, right?
Right,
And so rather than having to kind of come from more of a neutral state, from a negative back to a neutral, they're able to come from a negative more to a positive.
right, exactly. That they have, or maybe it could be I know this was just a state measure, but if it's like
Mhm.
if it's their trait, like they have maybe certain traits of like that keep them in a more positive mood, whether that's changing how they think about the cue exposure, or they have already done um, work to improve their mood overall. Yeah. Anyway.
Yeah, no, that's a great idea, right? So something that we haven't had a chance to do yet is to really to examine this kind of resilient responder group a little bit more. But I 100% agree with you, right? That it would be really interesting to learn like what is it about them that tends to make them a little bit more resilient. And I think you have some great hypotheses about that, right? Like you said that maybe they've already done some work around this. Maybe they have a few better regulation strategies that help them to recover more faster, right? Or help them to move from a negative to a positive mood a little bit quicker. So these are some things that we're going to be looking into, but I don't have data to back up any specific things yet.
Yeah. Oh, interesting. Thanks.
Yeah, but those are great thoughts though to kind of think about, right? Like what is it, if they're already kind of starting off a little better, right? Maybe there's something that they're something about them that's making them a little bit easier to recover.
Right.
Yeah. Yeah, no, that's a great idea. All right. So one more expansion on this that we've done recently was we wanted to look at what emotional responding looked like in the context of treatment. And this might get Nathan to your point a little bit, though. Again, it's not quite there. We weren't able to look at that resilient responder group quite the way that we'd like to. But something that we did, there was a large randomized controlled trial that the VA did that looked at whether or not differences in integrated treatment, so having treatment for both PTSD and substance use happen at the same time, or having a phased condition, right? Having substance use treatment occur first and then completing PTSD treatment second, whether or not that affected treatment outcomes. So we had 51 participants from this larger study, where we were able to look at their actual therapy data, which collects information about levels of distress in the context of treatment. And we'll talk a little bit more about what this treatment looks like in a little bit. But we were able to look at emotional responding while somebody was in treatment, and to see, you know, how does treatment kind of affect emotional responding, and in turn affect their symptoms. So what we did was like we said, we looked at these relationships between these emotional responding characteristics and then their levels of PTSD and substance use symptoms. So if we think back to this graph again, right, we're kind of looking at two pieces here. We're looking at how distressed were these people during treatment, and then how quickly were they able to recover from that distress during each treatment session. So both the effective intensity and recovery. And what we did was we looked both at the beginning of treatment, so at the very first treatment session that they had, and then we looked at what their responses looked like across treatment. So on average, across treatment, what were their responses and how did that change? And what we found was, if we're looking at just that very first treatment session, that there weren't any significant differences based on emotional responding in terms of PTSD or substance use. So it didn't necessarily affect how people's symptoms looked at the beginning of treatment. But when we looked across treatment, something that we saw was, again, those that had those higher levels of distress across their treatment sessions, right across the whole program, predicted that they were going to continue to have greater PTSD symptoms severity. So that's what this kind of top graph looks at here, is we've got kind of two lines, right? And the one line at the top are people who did not recover, right, during those treatments. It took them longer to recover from those sessions. And then the bottom line is folks who did recover more quickly. And so what we saw, like I mentioned, is that those with greater intensity, right, had higher PTSD symptoms, and those who had poorer recovery, right, didn't recover as quickly, were trending right towards this kind of worse PTSD symptoms. They were kind of staying more symptomatic across treatment, as opposed to those who had these changes in response to treatment seemed to be getting better overall. Now, again, we had such a small sample, so there was a lot of variability in terms of people, so this wasn't statistically significant, but we can at least kind of start to see a little bit of a trend that's emerging. We didn't see, again, any significant differences in terms of the substance use itself, but something that was interesting just to kind of look at in terms of the graph was, again, those who had that dotted line being that poorer recovery. We started to see that even though during treatment, they were pretty much the same and everybody was kind of decreasing their substance use. But once treatment started to end, right towards the end of treatment, we do start to see that those with poorer recovery look like they may be starting to return to their baseline levels of substance use, while those who are seeing those changes, positive changes in response to treatment, are continuing to decrease. So this is something that we would like to look at further to be able to explore that, and maybe over a longer follow-up period, especially, maybe after treatment has ended. But this was just something kind of preliminary to be able to examine, like, how does treatment actually affect emotional responding and symptoms in that way. So kind of taken together across a lot of the research that we've done, what we're seeing is, again, right, those who have that higher level of distress and take longer to recover from that distress, that appears to affect, right, their risk for substance use, where they're experiencing higher cravings and therefore, right, experiencing this greater urge to drink in the moment. So we are seeing, right, that these kinds of emotional characteristics really are important for understanding both PTSD symptoms and substance use symptoms. And preliminarily, right from that study we just looked at, this is something that can be targeted in existing treatments, which is really exciting. But some of the things that we want to continue to understand about this, right, is who are the people that are at greatest risk, and start to use that as ways to better tailor interventions towards those people and make sure that we're targeting the people with the right interventions at the right times. A lot of the work that we've done too has really been in a laboratory, right, or kind of in this um, uh, not natural context, right? Kind of writing about something online, being, listening to a cue in the laboratory. So something that we want to understand a little bit more is what emotional responding to trauma cues looks like in the real world as people are going about their day-to-day lives. And we're also really hoping to expand our understanding of what kind of support do people need in those moments when they're experiencing those high cravings. So that's some of the future directions that we're looking at. What I wanted to do briefly was actually to switch gears and to talk a little bit about what treatments exist for PTSD and substance use comorbidity at this point, and then to kind of start to build on what's missing. So we do actually have at the VA, we do have some clinical practice guidelines that guide what's recommended. And importantly, there are kind of really two approaches that exist in clinical practice. And like we were mentioning in that one study, one of the approaches is something called sequential, right? So this is you do one treatment first, and then you go to the next treatment. And the other one is a simultaneous approach where you're treating both conditions at the same time. What we found from a lot of the research so far is that really neither one is more effective or less effective than the other. So it really comes down to a little bit more about patient preference. But in practice, what tends to happen more often is the sequential approach, that most of the time one condition is treated first, and then once that's over, then you tend to move on to the next one. However, when we look at the clinical practice guidelines, this actually goes against what is often recommended. And in fact, what we see is that we're often told not to delay treatment for PTSD until substance use is in remission, though that is still often what happens. And as you can understand, probably imagine, right? Like people having concerns about, well, if I'm, treating the PTSD, is that going to make the substance use worse, right? Or put the person at greater risk for things like overdosing or, heavier substance use. And what we do see is that a lot of the top line recommended treatments are these trauma focused treatments. So treatments that go back to the actual traumatic events themselves and have the people kind of process and talk about those experiences. And importantly, again, a lot of the research that we see is that if the PTSD is treated, the substance use is often symptoms often improve. So a lot of the times in practice, what we see is that the PTSD tends to be recommended to be treated first, or at least at the same time that the substance use is treated. What I wanted to include here was a cool link that the VA has. They've created this really great treatment decision aid. So like I said, because the research really doesn't say one is more effective than the other, what it does is it lists a lot of the current top of the line treatments, and it lists pros and cons. It lists information about what they are. It links to videos about people talking about their experience in each of these treatments. And it's really useful when you're working with patients to try to discuss like what are your options and use a shared decision making approach around what treatment what should our treatment plan be. So I just thought that was kind of cool to include. So talking a little bit about what treatments exist. So one of the most common treatments for PTSD, especially used at the VA, and I think at Penn as well, is prolonged exposure therapy, right, or PE. Again, I'm not sure how familiar folks are with this, but the VA has created this really cool video about it. So I figured I would actually just show that. And hopefully you can see, hold on. Share my screen for the video.
If you have post-traumatic stress
Can you guys hear that? You can.
disorder or PTSD, it's common to feel like there are places or situations that are unsafe. it may seem like the best option is to avoid them, staying away from people or places that feel dangerous or reminders of a traumatic event. As a result, you may develop I can't rules. I can't leave the house at night. I can't trust anyone. I can't handle crowds. But these rules won't help you overcome PTSD. So how do you learn to say I can? Prolonged exposure, or PE, is a treatment for PTSD that helps you do safe things you've been avoiding. In PE, you and your therapist will practice exposure, meaning you'll work to approach things you've steered clear of since the event. You have to challenge your I can't rules to prove to yourself that you can. Remember when you were learning to swim or even drive a car? It was challenging at first, but got easier with practice. Exposure gets easier with time. With your therapist, you'll take steps to do the things that have been hard for you at your own pace. So if you're avoiding the grocery store, you might start by going when it isn't crowded, maybe bringing a family member along. You'll eventually practice going on your own, perhaps even during peak hours. With practice, you'll find that you can handle it. You'll also talk through the details of your traumatic event in a safe, gradual way with your therapist. Closing your eyes can help you concentrate. Retelling the event may sound like the last thing you want to do, but it helps with emotions like anger, guilt, and sadness. You'll listen to a recorded version at home too. After a few months, you'll find that you can talk about your trauma without feeling so overwhelmed. Prolonged exposure doesn't erase your trauma, but it can help you keep your traumatic experience from getting in the way of living your life. PE doesn't require you to take any medications. With your therapist's help, you'll follow a step-by-step program for about 3 months. Most people who complete PE show noticeable improvement in their symptoms, and many no longer have PTSD. Prolonged exposure works well for both men and women, and it's evidence-based, which means PE has been proven to work in multiple research studies. If prolonged exposure sounds like it could be right for you, talk to your doctor about finding a PE provider, or visit the National Center for PTSD website at www.ptsd.va.gov to learn more about PE and other PTSD treatment options. No matter how long you've been living with PTSD, know that you can get better.
Yeah, so those are some of what they call whiteboard videos, and the VA's created a whole bunch of them. But I think it's cool because, again, it kind of just is a patient-friendly way of talking about what these interventions are like. And I thought for our purposes, that would be nice to kind of share. But like we mentioned, right, so the traditional PE model kind of focuses on two pieces. So it addresses PTSD symptoms by, one, using imaginal exposures to go back to the trauma memory and repeatedly kind of revisit that memory and help process a lot of the information and organize the memory in a way, right, that allows the person to kind of heal from that traumatic experience. While they're doing that, they're also doing these additional exercises that have to do with commonly avoided situations, activities, places, or people, and it's helping them to kind of, to reduce that avoidance and to be able to build some mastery around experiencing things that have been really difficult in the past. So this is a treatment that we use very, very often. And there's actually several randomized controlled trials that have looked at this, not just for PTSD, but looked at it for PTSD and substance use. And so it's a really common treatment approach that's used for this co-occurrence as well, and can be really effective. Equally in line with that one is cognitive processing therapy. So, I mean, they are pretty much neck and neck in terms of what works best for who. But cognitive processing therapy works very similar to PE in the sense that it's focused on the trauma itself. But what it does is it kind of comes at it in a slightly different way, where it's looking more at the thoughts that someone's developed around the traumatic experience. And in particular, what they call stuck points, that's keeping a person stuck from being able to move past what's happened. So what you do in this treatment is you kind of identify, right, what are these problematic thoughts that are coming up? And then you work through some different tools and skills to help build more balanced and more accurate thinking about things. So as just as an example, if someone, has had a traumatic experience and they've since kind of really developed this thought, right, I should have prevented my friend from being killed, right? And this is something that when they think this thought, it brings up tremendous guilt, right? And this is something that they have not been able to get past and have not been able to move forward from. Throughout PE, something that you'll do is you'll talk a little bit about that thought. You'll help them to kind of explore, well, what is it that's kind of supporting that? Why is it that you think you should have been able to do this? Why is it is that really based on fact? Is that really based in, what happened? Is it more based on a feeling? Is there actual evidence that supports it? Or do we really find that it's just something that's kind of developed because something really horrible happened, and your mind is trying to find a way to prevent that thing from happening? And over time, what we try to do is facilitate kind of this more balanced view, such as, right, there was no way to know what was going to happen. I did the best I could given the circumstances, right? And you can really see that when we go from one type of thinking to the other, right, that it helps to facilitate a real change in how someone might feel, right? If you're thinking kind of that second version, you might still feel really sad about what happened, right? Because it's tragic to lose someone who you care about. That's a normal emotion that we can process. But that level of guilt, right, isn't going to be there because we're not feeling that same level of responsibility that is misplaced a lot of the times in these kinds of traumas. One of the other types of treatments, again, also focused on trauma, is something called EMDR, eye movement desensitization and reprocessing. There's another one of these cool whiteboard videos, so I do want to share it for this one too, just so that we can take a look at that. Oops. Oops, I shared the wrong screen again.
If you have post-traumatic stress disorder or PTSD, all kinds of things in everyday life can trigger a traumatic memory and create stress. Specific places, loud noises, large crowds, even everyday things at your home. The thoughts, feelings, and physical sensations you had during your trauma can affect how you feel, act, and think today. So how do you reduce the stress caused by these memories? One form of talk therapy that has proven effective for treating PTSD is eye movement desensitization and reprocessing, or EMDR. Memories can be made up of many images and related feelings, and EMDR helps you reprocess the trauma to experience it in a different way. EMDR starts with history taking. This involves describing important life events and the trauma you want to work on, as well as your treatment goals. You'll learn ways to manage your anxiety too. Your therapist will ask you to look back at the trauma and think, what negative thought about yourself do you have from that experience? What would you like to believe about yourself going forward? How bad does it feel to you right now? You'll start processing a memory from there. Your therapist will have you move your eyes back and forth while you think about the trauma and those related feelings. During this phase, new and useful information comes up, and old, painful thoughts, memories, and feelings fade and become less distressing. At the end of processing, you'll look back at the positive beliefs that you want to have about yourself. Processing is over when these positive beliefs feel true to you and there are no unpleasant sensations in your body. This phase of treatment may take several sessions. You may also work through more than one traumatic memory before treatment is over. EMDR doesn't require you to take medication. With your therapist's help, you'll follow a step-by-step program for about 3 months. Most people who've completed EMDR show noticeable improvement in their symptoms, and many no longer have PTSD. EMDR works well for both men and women, and it's evidence-based, which means EMDR has been proven to work in multiple research studies. If EMDR sounds like it could be right for you, talk to your doctor about finding an EMDR provider.
Perfect. So as you can see, again, very similar to the other approaches that we talked about, really focused on, again, the traumatic memory itself, the negative feelings, the negative thoughts that come up. But this particular approach actually adds this bilateral stimulation techniques of either that eye movement or sometimes a tapping technique that's added. And there's some back and forth about how effective that additional component is. There's some research that supports it. There's some research that says it's not. When they deconstruct it, it's really the exposure itself that's different. But this is another treatment that's offered, and it is one that does show when people complete it to help with both PTSD and substance use symptoms. And then the other avenue of treatment that's often recommended as a first line effort is medication. And now a lot of the times, right, these would be like anti-anxiety or antidepressant medications, really focused more just on symptom reduction, not necessarily focused on the trauma, not focused on addressing or processing anything, but just getting some relief from those negative symptoms. Like any medication, right, they're going to come with side effects. And then if you stop taking the medication, you might not necessarily see continued effects after that. So it's one of the downsides of this approach, but can be something if somebody's not able to engage in therapy right now, is just looking for ways to minimize some of the impairment, can be a really effective approach for that. So those are kind of our first line recommendations. But there's also some additional recommendations that if any of the first line approaches are not either desired or possible right now, that you can consider. There are a couple additional therapies that focus on very similar approaches to the ones that we talked about, but they don't necessarily address the trauma itself. So in cognitive therapy, right, you might not necessarily talk about the traumatic event or the traumatic memory, but you might just generally talk about, how someone's thinking is affected in their day-to-day life, and work on some techniques around, rather than the trauma itself, just around their general day-to-day. Present-centered therapy focuses more on, like we said, day-to-day interactions as well, and having people learn some problem-solving techniques that help them to manage their symptoms as opposed to go back to the trauma itself and actually address them. And written exposure therapy, even though it's a form of trauma-focused treatment, it's a little different than the other approaches we talked about because it really involves the person just writing about their experiences with the support of a therapist, but they're writing pretty independently about those experiences. So it's kind of a slightly different approach for it. So far, the approaches that we've talked about have really focused on just the trauma aspect, right? The PTSD aspect. And like we said, that's a really common thing, but there are actually starting to be developed some treatments that really integrate treatment for both PTSD and substance use. So I wanted to talk a little bit about those. One of these treatments is something called COPE, which actually integrates both the prolonged exposure therapy approach and also relapse prevention for substance use. So they are talking about PTSD and substance use at every session. And this is a way that you can work on both PTSD and substance use at the same time without necessarily having to meet with two different providers or do two different treatments. So it's a really great approach for that. We also have more of a present-focused approach, something called seeking safety, which is often in a group format, but can be done individually. And this one doesn't focus on treatment, but really focuses more on coping skills and building skills around managing PTSD symptoms and substance use, and building more self-compassion around the self. So these are, again, I think two really exciting approaches that are still new. So they're not yet part of the clinical recommendations, but are really great approaches that that rather than just focusing on one aspect of someone's experience, they really try to integrate tools and techniques for both. The VA has some additional resources that are pretty cool to help people out, and some of that is app-based support. So like we were talking about, right, that something that comes up is that people really need support outside of therapy as well. And so the VA has started to develop these app-based treatments that can be accessed either independently or even, you know, in addition to therapy that someone's doing. And they're free, so you can actually go onto the App Store and download them and take a look at them yourself as well. But they have ones that are called PTSD Coach and PTSD Family Coach. These are pretty cool because they have a lot of great psychoeducation about PTSD. They have some different tools and techniques that people can use to manage symptoms. And the Family Coach is really great if you are a family member of somebody who's experiencing this, in terms of how can you best support that person, either in the context of treatment or just in their day-to-day life, and how can you understand a little bit more about what they're going through. They've also developed an app specifically for alcohol use. It's called Vet Change. And this one is also really great in the sense that it allows people to monitor what their drinking is like. So you can record the number of drinks that you have each day, and that'll keep track. So you can kind of graph out, you know, like how your use is changing. It includes different tools to monitor mood, different emotion regulation techniques or relaxation techniques, more psychoeducation about substance use and PTSD, you know, what a standard drink is, what are some of the risks of drinking, things like that. So these are great resources. But something I wanted to do was just highlight, like, while we do have a lot, there's still a lot that we can really build on in this area. Right. So as we were talking about at the very beginning, for people who have both PTSD and substance use, these treatments are more challenging for them to complete. Right. And we can imagine that, given kind of what we just learned about them, that you know, somebody who's experiencing more life stress is going to have a harder time sticking to 3 months of treatment, right? Once a week. You know, attending it consistently without dropping out, is going to have a harder time managing some of the distress, especially for those trauma-focused treatments. And so, like we said earlier, right, people with PTSD and substance use are much more likely to drop out of these treatments at a higher rate than people with just PTSD. So it's challenging because even though they work, we do see a large group of people who aren't able to get the full dose of treatment and really aren't able to get the benefit. Like we said, despite the guidelines, which say that we shouldn't delay treatment, in practice, a lot of people are quite hesitant to engage in some of these PTSD treatments while someone is actively using substances because of concerns about safety or exacerbation. And so that can be just a difficult clinical challenge to manage. Treatment, like we also mentioned, is often really siloed and disconnected. So a lot of the times these treatments are delivered by separate providers and separate clinics, and that interplay between PTSD and substance use that we were talking about at the beginning really isn't often discussed as part of treatment very often, with the exception of those two newer integrated treatments that are actually doing that. But yet, like we said, the evidence and experience for that is still building. A couple other things that I think are really important that I wanted to highlight, right, is that therapy itself is only an hour out of an entire week. So if we really break that down, it's less than like 0.01% of our time. So there's a lot of time outside of therapy sessions that people are really struggling and needing support, and that we're not yet addressing, right, or we don't yet have resources for them for that. And a lot is happening in between those sessions that may not always get addressed in treatment. So even though we are starting to see some of those app-based resources that are trying to kind of, you know, fill this gap, sometimes those can be difficult to navigate independently if the person's not feeling very tech savvy, or if they are, you know, a lot of them really require the person to navigate them on their own. So to look for the information, to have to find the tool, to have to, you know, read through everything, and that can sometimes be really difficult. So I call it kind of this kitchen sink approach where it throws everything logging into the app, but there's really no personalization or recommendation about this is a tool that's going to be helpful for you, or this is a tool you should use right now. So that's actually where a lot of my future research is going, is trying to fill in this gap. So one of the things that we've started to do is to use a technique called ecological momentary assessment, or EMA, to be able to better understand what people's experiences look like in their day-to-day lives. So they answer these really short surveys about their experiences. And then that gives us a glimpse, right? Kind of a window into their experience throughout the day. This is a field that's definitely growing pretty quickly, but is a little bit newer for the VA. Hasn't been done as much within the VA or with veterans. And what we're trying to do is to move towards a newer approach called just-in-time adaptive interventions. And basically, kind of like the name suggests, right, these are app-based treatments that would be integrative, like those, the COPE or the seeking safety approach. So it incorporates both skills and tools for PTSD and substance use, but is informed, right, by these EMA surveys. So based on what someone reports experiencing, right, it would pull information or content from the app and be able to forward that to the person so that it really personalizes the treatment based on their experience and based on what they need most in the moment. You start to kind of develop these decision rules about, if somebody says this is the content that they should look at. If they say this is what they should look at. And there's a lot of preliminary work that's needed to develop these treatments, as you can imagine, to be able to make them work and function appropriately for not just for the individual, but for the population at large. So that's kind of the new area that we're trying to start to build on. Just to give you a glimpse into what this is looking like so far, what we did at the VA is, again, because EMA is a relatively new technique especially within the Philadelphia VA, what we wanted to do was just to see, how do veterans feel about answering these EMA surveys, right? Is this something that they would even do or even okay with doing? So we had a sample of about 30 veterans who completed 30 days of these daily surveys. And what we asked them to do was, using their own smartphones, we sent them 5 surveys randomly throughout the day, and we asked them to answer them. Surveys were really short. They were less than 3 minutes, and just asked them about things like emotional responses to trauma, cravings for substance use, what types of strategies they were using to manage that distress, things like that. And it was cool because there is this app that the VA has developed called MPro that actually allows us to do that behind the VA firewall. So it's still very private and protected, which is really important for a lot of veterans. But it allows us to still get their information and to understand what it is that they're experiencing during the day. So just to give you a little glimpse as to what this app looks like. Again, it's an app that you download right onto your own smartphone, so they don't have to have a separate device or anything like that. We give them a survey code, and then throughout the day, they get these little notifications that pop up that tell them when a survey is ready. They'll go in, and then they can take the survey right in the app. Some of the questions, like I mentioned, that we asked them was, we wanted to understand kind of, again, what does emotional responding look like? So we had them read this blurb about what a trauma reminder is and, what could, be considered a trigger. Ask them if they had experienced that, at different points during the day, and then ask them to rate their level of distress to those experiences. We also asked them about urges and cravings, and same thing, asked them to rate like how intense those cravings were. And what we found was that that this was really feasible for folks. So a lot of people did the surveys. We had really high rates of compliance, and we had most of our sample, 94%. So with the exception of one person, everybody completed the full 30 days of monitoring, right? Which, if you can imagine doing something for 30 days, that's pretty impressive. So we were really happy to see that this wasn't something that felt burdensome. It wasn't something that felt negative for people. In fact, when we asked people people about how they felt about it, they really felt generally very positive about the experience. And in particular, some of the benefits that they really mentioned was one, that answering these surveys throughout the day helped them to be more self-aware of what they were experiencing and how their symptoms were interrelated. And they actually preferred answering questions through the app more than they did in other ways, because it was more private, it was more convenient, and it was just something that was easy to do. So what we're going to do, or what we are doing right now, is we're actually expanding this to a larger study to now be able to actually look at some of these relationships, the mechanisms that we were talking about at the very beginning, but in people's daily lives. So we're going to be taking a look at what does emotional responding look like as people are going through their day-to-day? How does that relate to their craving? And then how does it relate to their overall substance use as well? So that we can start to better understand those connections, and two, right, to start to understand what are some of the factors that influence, right, what either offers protection for somebody or increases their risk. So in addition to looking at just what their emotional responses look like, we're going to also be asking them about other things, like what kinds of emotion regulation strategies do they use? What are some of their motives for why they want to drink in the moment? What's their level of tolerance for the distress that they experience? Stuff like that. And then very much in line with that community engagement approach that I was talking about, we really want to incorporate veteran voices from the beginning. So throughout the process, we're going to be getting feedback from veterans about this experience and how they feel about not only answering these questions, but what they want to see in a just-in-time adaptive intervention, if this is going to be created for them, and especially what they don't want to see. So this is kind of what the larger project will look like. We're going to have about 125 veterans complete a period of EMA. They're going to do about 4 surveys a day. And like I mentioned, right, we're directly informing a lot of what we're doing based on their feedback and their input. So I thought I would just end the presentation today with a brief quote from a veteran who I was working with in our substance use clinic, right, that I think kind of captures the spirit of not just, where we are, but where we want to go, right, how we want to expand treatment for this group. And something that he had said was, sometimes it's not even one day at a time, but one moment at a time, right? And I think that, again, we have some great treatments that work, but something that we really need to do to be able to grow, and expand treatments and, for people, is to be able to offer more support in these moments when people are really needing them. And so that's kind of what we're hoping to do moving forward. So I want to thank everybody for, joining the presentation today. Wanted to open it up to see if there were any other questions or comments. I did put my email here, so if you do have any questions later on or interest in learning more about any of the studies that I shared or the treatments that I shared today, please feel free to email me as well. But thank you, everybody, for listening.